Sure. All right. Okay, so good evening, everyone. And this was a totally unplanned webinar that stemmed out of one WhatsApp conversation that we had. We've had about 15 webinars on different topics, but in which we discussed the latest evidence. But the first step is to understand how to correctly interpret evidence. And we could not ask for two better people than Dr. Ramakrishnan and Dr. Penumadu today, who are going to tell us how to interpret the results of a trial, how to critique a scientific paper. So over to Dr. Penumadu to moderate the session.
Thank you, Dr. Aditi. I think Dr. Ramakrishna needs no introduction. And listening to him, I think just before everybody else logged on, Aditi made a statement: if you send a paper to Dr. Ramakrishna, it'll all be in black and blue. And I think it's very important to critically analyze a paper, not just for the sake of criticizing it, but to actually understand it. Every manuscript, I feel, will have some limitations. There is no study without limitations. But whether we can actually take this results into our regular practice, or can we take every manuscript that gets published and take it into our routine practice, is something which is very important. So I think today, over the next 1 hour, we will have Dr. Ramakrishnan sir telling us about how to critically analyze a paper. And I request all of you all to mute your mics, because it's a single platform. And I would encourage you all to put questions in chat box so that we can ask the question, and then there can be a one-on-one interaction rather than each one of you all speaking. Okay, so over to you, sir.
Thanks, Prashant. I'll just share my screen. Are you able to see this?
Yes, sir. Screen is seen. Can we make? Yes, sir. Now it's full screen.
Okay. So thanks, Prashant, and thanks, Aditi, for asking me to talk about how to make sense of a scientific article. So while we were discussing the HiPEC T4 paper that was published recently, Aditi suggested why not do a proper appraisal of it in our platform. So I will use this HiPEC T4 paper as an example of how to do a critical appraisal. So basically, I would be reviewing this published article, and at the same time also try and put in points on what you should see while you analyze published article. So what is critical appraisal? It is the systematic evaluation of public clinical trials. So please remember, it is the idea of a critical appraisal is not to criticize a paper. Remember, investigators have spent years doing the research, and finally they write the results of their research. So we need to be kind to them when we are reviewing the papers, but at the same time, look at the strengths as well as the weakness. So that is the idea of critical appraisal. Most of us, at least me, when I started reading scientific papers, I used to look at the abstract, I used to look at the results, see if there was a p-value that was less than 0.05, and then conclude that, yes, this is a positive study and the results needs to be followed. But down the line, I think we all have realized that that is not the way we go about reviewing a paper. So please don't look only at the result. A so-called positive study is not always a strong study, and a so-called negative study is not always a weak study. So rather, what we need to do is look at how a study is conceived, how is it designed, how is it conducted, how is it analyzed by the authors, how is it interpreted, And finally, how is it reported? Yeah. So during a process of critical appraisal, we seek to establish basically 5 questions. One, is the study addressing a clearly focused question? Second, did the study use valid methods to address this question? This is called the internal validity of the study. That is how well designed the study was. Third, is the valid result of the study important to me, to my patient, and to everybody else? And whether these are applicable to my patient or population, this is called the external validity of the study or the reproducibility of the study. And finally, you should also see whether there is any spin or bias in reporting, whether the authors have correctly reported their findings and how they have interpreted this results. Okay, so this is the paper that we are going to review today. This is the efficacy and safety of intraoperative hypothermic intraperitoneal chemotherapy for locally advanced colon cancer, a phase 3 randomized clinical trial. In short, it is called the HIPEC T4 trial. This is published in JAMA Surgery. JAMA Surgery, as you all know, is the highest ranking surgery journal in the world with impact factor of 16.7. So that tells you something about how important this study is. This is published by a group of surgeons from Spain, led by Alvaro Aruna Sanchez. And it was funded by the public health system and the Spanish Association of Surgeons. So these are very important things that you need to know: in which paper, which journal the study is published, who has funded the particular study, whether it is investigator initiated study funded by a public enterprise or funded by the pharma company. So the first thing we all do when we look at a study is read the abstract. Now, different journals have different formats for writing the abstracts, but basically the abstract just gives you a gist of what the study is, why the study was done, how and where the study was done, the methods, what are the important results of the study, and what is the conclusion of the study. So it's important to go through the abstract, but 3 important things that you need to note in the abstract. Does it explicitly state the primary endpoint? An abstract must state what is the primary endpoint. Here, this is the abstract of this study. The primary endpoint is 3-year local regional control rate, and it has been clearly stated. So I'm going to put smileys depending on whether I feel this is done satisfactorily or not. So I feel this is satisfactorily done. The second thing is the toxicity reported in the abstract. Yes, they have mentioned that there is no difference in morbidity or toxicity between the 2 groups. And finally, does the concluding sentence of the abstract pertain to the primary endpoint? So that gives an idea whether the authors have concluded a valid conclusion based on the results. Again, here, based on the results, they have concluded that addition of HIPEC to complete surgical resection in locally advanced colon cancer improved the 3-year local control rate compared with surgery alone, which was actually the primary outcome measure. So the abstract is quite satisfactory. So now let's come to the 5 questions that we need to address. First, does the study address a clearly focused question? You get this information from the introduction. So how do you know that a study is addressing a focused question? Is the scientific background and rationale adequately explained? Is the research question scientifically relevant? Which means, is it a clinically important question that they are seeking to answer? Is the study an original study? If it is not, how does it add to the literature? And was the objectives or the hypothesis to be tested stated clearly in the manuscript? Now let's go through the introduction. The authors begin by saying that colorectal cancer is a highly prevalent disease and peritoneal metastases are diagnosed at an advanced stage and symptomatic stage and are usually associated with a poor prognosis. They enumerate the various risk factors for developing peritoneal metastasis and say that the incidence of metachronous peritoneal metastasis in PT4 colon cancer has been reported to be up to 36%. So they are quoting the upper limit of the range when they are saying 36%. They then go on to say that patients with PT4 colon cancer are usually treated with systemic therapy, which usually does not prevent peritoneal metastasis to the extent that we would like it to. They say that there is only one previously published phase 3 randomized trial of prophylactic HIPEC, which used oxaliplatin. You might be familiar with the COLOPEC trial published by the Dutch group, which did not find a benefit of HIPEC in preventing peritoneal metastasis. So the objective, they state, the primary aim of this trial was to determine the efficacy of intraoperative HIPEC with mitomycin C with complete resection of locally advanced colon cancer. They have not stated the hypothesis anywhere, but we assume that being a superiority trial, they hypothesized that HIPEC does reduce the incidence of peritoneal metastasis. Now, is this a novel study? The authors have already mentioned that there was a previous study, phase 3 randomized trial on prevention of peritoneal metastasis in colorectal cancer. So is this a novel study? Is this an original study? If you look at the COLOPEC trial that was published in 2019, it included clinical or pathological T4 or perforated tumors. So as we move on to the eligibility criteria, we'll find that perforated tumors were not included in this trial. HIPEC in the COLOPEC trial was performed either simultaneously with the primary surgery or within 5 to 8 weeks, whereas in the current study that we are evaluating, HIPEC was performed at the time of primary surgery. The COLOPEC trial used oxaliplatin for HIPEC, sometimes mitomycin, sometimes irinotecan also, but mostly oxaliplatin, whereas the HIPEC T4 trial, as we will see, used mitomycin only. There is one more trial which is probably not very similar to this study, but also is a study trying to see if prophylactic HIPEC is useful in preventing peritoneal recurrence. This is the Profellowship or the French Prodigy 15 study. The inclusion criteria in that trial were all patients with synchronous and localized colorectal peritoneal metastasis, which were removed during the initial surgery. It also included perforated tumors and resected ovarian metastasis. And differently from this HIPEC T4 trial or the COLOPEC trial, the second look surgery was done after completion of adjuvant chemo, and HIPEC was given only at that time. So this trial is different from the previous two published trials. So it is quite novel in that way. So is the scientific background and rationale adequately explained? Yes, even though they have not said explicitly what the rationale is, they have attempted to explain the scientific background and the objectives. Is the research question scientifically relevant? I would say yes, because it is an important clinical topic, a very highly prevalent cancer with possibility of peritoneal metastasis, the results of treatment of which are quite poor. So any attempt to try and reduce the peritoneal metastasis would be welcome. And therefore, I think this study is scientifically relevant. Are the objectives and hypothesis to be tested stated clearly? Yes. Now moving on to the second part, the second question that we need to address: did this study use valid methods to address the research question? So this is called the internal validity of the study. Basically, we are looking at how this trial was designed and how this trial was conducted. So again, there are 5 questions that you need to look at here. So you can start using checklists. There are different checklists that are available for helping you to do the critical appraisal. A lot of them are published. You can choose any one. But these are the common questions that you need to look into. Was the design of the study appropriate to answer the question? Were there systematic errors in the study? What do you mean by systematic errors? You have to look at the participant intervention control outcome, that is the PICO. You look how the study was randomized. Was the study blinded? Blinding in a study avoids performance bias, avoids treatment bias, and avoids assessment bias. Contrary to expectations, surgical trials can be blinded. but we will go into that question later. How was the study conducted? Did each study group receive the same level of care? Was there a mechanism to ensure quality control? Was an interim analysis plan? Then look at the random errors. Random errors involve the statistical methods that were employed and how was the sample size calculated? Was it appropriate or not? Then finally, look at whether the study was approved by an ethics committee, and very importantly, was the trial registered with a recognized trial registry. Almost all trials now are registered with a recognized trial registry, and unless they are, they don't find their way into any journals. So now let's look at the PICO. Now, all these questions will be answered if you go through the methodology section of the published article. So the setting and location where the study was conducted, they have mentioned that this is a multi-center trial which was conducted in 17 cancer centers in Spain. Whether the design was appropriate, yes, this was a randomized phase 3 randomized control trial, which is probably the best way to look at any new intervention. It constitutes the highest level of evidence. Now, regarding the eligibility criteria, they included patients aged 18 to 75 years with a histologically confirmed adenocarcinoma of the colorectum above the peritoneal reflection, clinically staged as T4, node negative or up to node N2 was allowed, but M0. Patients had to be in good performance status. So it's a fairly broad inclusion criteria. The broader the inclusion criteria, the more reproducibility this study will have. The exclusion criteria, obviously presence of metastasis, incomplete resection or presence of unresectability criteria, any emergency surgery for an obstructed or a perforated tumor was a exclusion criteria. Extraperitoneal rectal carcinoma was an exclusion criteria, and all the other usual exclusion criteria that you find in the study, including if the patient had received any preoperative cancer-directed therapy. So I think we are quite satisfied that they have clearly stated the eligibility criteria and the settings and location where the study was conducted. Now, next, going on to the interventions. Does the study precisely describe the intervention used in the study? Now, let's look at the intervention. All the patients received extensive cytoreductive surgery and target surgery, either laparoscopic or open. So, which means the control arm as well as the interventional arm required complete tumor resection with extensive lymphatic node resection. They have not mentioned what is extensive lymphatic node resection. They also need to have undergone an omentectomy, appendicectomy, and bilateral oophorectomy in postmenopausal women. In the interventional group, in addition, immediately after cytoreduction, patients received HIPEC. They have given details of this procedure, the drug use, mitomycin, the dose, 30 mg per meter square, what is the perfusant, dextrose 1.5 liters, what is the volume, 4 liters, timing, 60 minutes, temperature required to be maintained between 42 and 43 degrees centigrade. They did not allow any dose substitution, dose modification, or drug substitution. Common to both arms, at the completion of surgery, both arms patients received adjuvant systemic chemotherapy within 12 weeks, according to the local treatment protocol. So yes, the study did describe the interventions used. The appropriate comparator was used. Now here, I am not very satisfied that an appropriate comparator has been used. The study aims to see whether HIPEC reduces peritoneal recurrence in relation to standard treatment. Standard of care surgery usually does not include cytoreductive surgery like an omentectomy or appendicectomy or bilateral oophorectomy. So this is something that we can discuss. Should the comparator group have received cytoreductive surgery? As I already told you, it's not standard of care. The risk of developing ovarian metastasis in a colorectal cancer is around 1 to 8%. On an average, it's around 4%. We can understand in the presence of peritoneal metastasis, removal of the ovary makes sense because there is an incidence of 17% occult metastasis in such a situation. So was an ovariectomy required? What about omental metastasis? Aditi has analyzed and published her paper on occult metastasis in different target sites in the omentum and colorectal cancer. It is supposed to be around 12 to 15%. In spite of this, this is not standard surgery for most of us. So, was this an appropriate control? That is something that we need to discuss. The other thing that the authors have not mentioned in the methodology, in the how the details of the intervention, is what was the treatment at relapse. This is neither mentioned in the paper nor is it mentioned in the protocol, which is provided as a supplement. Now, moving on to the outcomes, have the primary and secondary outcomes been clearly defined? Are they appropriate or important to the patient, or are they surrogate outcomes, and are the methods of assessing the outcomes specified? So, as we saw in the abstract, the primary outcome was the locoregional control rate. At 3 years, they have clearly defined it. Proportion of patients without pathological or radiological diagnosis of peritoneal of locoregional recurrence, which is defined as relapse of disease either in the abdominal cavity involving the peritoneal surfaces or the tumor bed. This was a single primary endpoint. The secondary endpoints were disease-free survival, overall survival, morbidity, and mortality. And the survival rates were analyzed from the surgical treatment up to the end of follow-up or up to the event. Now, how do they diagnose peritoneal relapse? Either by additional imaging tests like a CT, MRI, or even a PET scan, with or without a percutaneous or surgical biopsy. The follow-up was performed every 6 months with clinical imaging and evaluation of tumor markers, and they have assessed the toxicity using the CTCAE version 4, and also looked at the perioperative mortality at 30 days and 90 days after treatment. So the primary outcomes, secondary outcomes have been clearly defined. Now, are they appropriate or important to the patient? Again, I'm not entirely satisfied with this. Are the methods of assessing the outcomes specified? They have been specified, but are they adequate? So this is again something that we need to discuss. What outcomes are important to the patient? Ultimately, for a patient, what matters is that they either live longer or they live better. That is an improvement in the overall survival or an improvement in the quality of life. Here, overall survival has been mentioned only as a secondary endpoint. So is a locoregional control rate a valid surrogate marker for overall survival in colorectal cancer? There is no data regarding this. We know that there is enough data to say that disease-free survival is a valid surrogate for overall survival in colorectal cancer, but not a locoregional control rate. I did not come across any evidence to say that the locoregional control rate is a surrogate for overall survival in colorectal cancers. The other thing, they have also not assessed the quality of life, although if you go through the study protocol in the supplement, they had mentioned quality of life as a secondary endpoint. They have not mentioned that in the manuscript, nor have they given any results of the quality of life. Again, there was no central review of locoregional recurrence. A multi-center study, it is always preferable to have a central review of the primary endpoint, whatever is possible to analyze, like the CT images or a biopsy reports, etc. Here, the biopsy confirmation was not was not mandatory. Now, if you look at the Profilo-CHIP trial, nearly 50% of patients without any radiological evidence of peritoneal disease were found to have peritoneal mets on second look laparotomy. So, how effective is your CT scan or MRI or even a PET scan in diagnosing peritoneal relapse? So, if the patients were free of peritoneal disease at the cutoff point, which was 3 years, does that really mean that they were not harboring peritoneal disease at that time? We do not know for sure, because they might have had small disease which probably was not picked up by whatever imaging was done at that time. They had not mentioned, they had not made biopsy of the recurrent lesion mandatory? Now, this is debatable. Most trials don't make it mandatory. If it is an unequivocal finding on an imaging, most often a biopsy is not mandatory. But if it is an equivocal finding, usually most trials insist that biopsy be done to confirm that an event has happened. Now, it is known that there is a discordance between even an intra-op PCI and a pathological PCI as high as 46%. So if you don't do a biopsy of a target lesion that you identify on an imaging, can you conclusively say that the patient has had a recurrence, that the patient has had an event? This is again something that we need to discuss. I'm not saying this is a flaw in the study. This is just something that you have to keep in mind and discuss. Now, how was the randomization done? Was an appropriate method of randomization used? Was it sufficient to eliminate systematic bias? Was the allocation sequence concealed from investigators and participants? And was there blinding? Now, it was a central randomization. The randomization was done preoperatively. It was done at a 1:1 ratio, and the clinical team was masked to the randomization process. So this is allocation concealment. This is different from blinding because allocation concealment is preventing for disclosure of the arm to which the patient is going to be randomized. This prevents a bias in the sense that you don't know to which arm that the next patient that is going to come is going to be randomized. Because if you know, then you are likely to eliminate that patient if you think that patient is not a good patient for the arm to which he is going to be randomized. So allocation concealment is a must if the randomized trial has to be done properly. So here the clinical team was masked to the randomization process. The other details, it was a central randomization using a red cap stratified according to the treatment center and the sex. And by just pressing one button, they could obtain the details of randomization. And they go on to say that because this is an open label study, there was no blinding. And they, in the protocol, they justify why blinding was not considered, because they say at the time of discharge, the patients will need to get details of what treatment was done, so they cannot hide that from the patient. Secondly, the insurance companies will also insist on the details. So there also the patient is likely to come to know. So they said blinding is not possible. So is that going to be a problem? So most of the other things are satisfactory. I wouldn't say that because they have not blinded the study, it is a flaw. Blinding is important when blinding is going to influence the endpoints that are going to be assessed. Here, the endpoint, primary endpoint, was loco-regional control. That is never going to be influenced by the patient or the investigator. That is in neither of their arms, nor of any of the secondary endpoints. So even though this trial was not blinded, that is not a serious flaw at all. Now, can surgical trials be blinded? Yes, here the patient could have been blinded, but as I told, it is not going to influence the results of the study. So it is really not going to matter. So next, coming to the conduct of the trial. Now remember, a randomized trial only ensures that both the treatment arms are comparable at baseline. That means there is no selection bias. That doesn't mean that bias cannot happen during the conduct of the trial. So it is always important to see how the trial was conducted. Did each study group receive the same level of care? How do you know that? Is there a clearly defined study protocol that says what is the level of care that was given to either of the two arms? Yes, here there was a study protocol which was provided as a supplement. Many trials publish their protocol well in advance of the actual paper. So that is another source for getting this information. So yes, both groups did receive the same level of care. You need to also look at whether they were followed up evenly, whether they got the same, except for the intervention, all the other treatments should be the same in both the treatment arms. So that's what I said. Any additional interventions were given where they're similar between the groups. So the adjuvant chemotherapy was same between the two treatment arms, because this will sometimes introduce an element of treatment bias or performance bias. And the follow-up was also similar in both the arms. So this eliminates assessment bias. Was there a quality control mechanism? They have not mentioned any quality control mechanism in the study protocol or in the published paper. Was an interim analysis specified? Yes, at the end of recruiting 100 patients, an interim analysis was supposed to be done. So now coming to surgical quality assurance. Unlike drug trials, there is a lot of variability in surgical trials because the surgery itself is a variable. No two surgeons perform surgery in the same way. Not just surgery, any trial of a technique needs to have proper quality assurance because that will itself introduce a bias. The survival rates here may show little improvement and it might fail to make an impact on the surgical practice. So it's important that surgical trials have an element of quality assurance built into the trials. 3 domains of surgical quality assurance that you must look into are credentialing, standardization, and monitoring. So I would urge you to read this systematic review, which mentions the mitigating strategies to challenges to quality assurance in surgical trials. So first is credentialing. I mean, so you need to know whether this is going to be a pragmatic trial or this is going to be a trial that is looking only at the efficacy of a particular treatment. If you're looking at the efficacy, you need to have credentialing of the surgeons and the hospital. This could be done by the volumes or by looking at the learning curves or reviewing the operative reports or asking the surgeons to send videos of the procedure, or sometimes in some trials the referee goes to each operating center and observes how the surgery is done. So there are different ways a surgeon who participates, an investigator who participates in a surgical trial can be credentialed. Next is standardization. You define the procedure. Here they have defined the procedure. They have defined permitted modifications. You educate all the surgeons using videos or pamphlets, conduct workshops and meetings to make sure that everybody is doing the same standard procedure in the intervention arm as well as in the control arm. It is not enough to just standardize. You need to monitor and make sure that this is adhered to. The methods are adhered to. You can ask the surgeons to send videos of surgery to a central team which will review and make sure that quality is maintained, or send photographs or record indications for various surgical decisions, look at the pathology reports and use standardized data forms. So unfortunately, they have not mentioned anything about surgical quality control in this trial. As we all know, there are so many variables in HIPEC: the drug, the dose, the perfusate use, the volume, the time, whether it is done closed or open, the flow rate, the temperatures maintained. There are so many variables. Even though they have attempted to standardize most of them, like the drug, the dose, the perfusate, the volume, even the temperature, but there is no monitoring of the temperature that is maintained. There is no central monitoring. So we don't know, at least it has not been mentioned, whether the uniform temperature, average temperature was mentioned during all the procedures of HIPEC. They have not mentioned whether it was a closed HIPEC or an open HIPEC, or the option was given to the participating surgeons. Now coming to the random errors. Was the sample size calculation appropriate? Were appropriate statistical methods used? This is a very important part of designing the study because the results are going to be influenced by this, and this is what is going to decide whether the study is going to be practice changing or not. So when calculating a sample size, you need some basic data based on which you can calculate the sample size. You need to know what is the baseline risk of the control group. You need to have an estimate of what is the minimal clinically relevant difference that you expect from the baseline or control group, what you expect in the interventional group. you need to know these two basic things when you're looking to calculate a sample size. So when you calculate a sample size, what you're actually looking at is the number of events. You ask any statistician, they will calculate sample size based on number of events. So they assumed in this trial that in the control arm, that is cytoreductive surgery with only adjuvant chemotherapy without HIPEC, at 36 months, they expected a 64% loco-regional control rate. That means they are expecting a 36% recurrence in the peritoneum or in the tumor bed. And they assume that with addition of HIPEC, the loco-regional control rate would jump to 82% from 64%. That means an absolute risk of recurrence at 3 years of 18%. So the difference in the risk of recurrence was 18%. That means from 36%, they aimed to bring it down to 18%. So they thought that this was the minimal clinically relevant difference that they should aim for. And the sample size was based on this. So the two-sided alpha was 0.05. The alpha denotes the p value that they think is statistically significant. The beta or the power of the study is 80%. Based on this, they needed a total of 190 patients, 95 in each group, and accounting for a 5% dropout, total of 200 patients were required to achieve the endpoint that they were planning. Now, was it an appropriate sample size calculation? As I'll show you, I'm not very happy with the sample size calculation. They used appropriate statistical methods to analyze the results, however. This is again something for discussion. Now, most of the published literature mentions incidence of peritoneal metastasis in T4 colon cancers as somewhere between 8 to 17%. This trial assumed a 36% risk of peritoneal metastasis, which is almost double the upper limit of what is normally quoted in the control group. And they assumed that there will be an 18% absolute reduction in the risk when HIPEC was performed. Now, the assumption of a very high incidence of peritoneal recurrence as baseline and a large benefit with the intervention was probably not correct in my view, and probably led to a smaller sample size than what would have been required. I'll elaborate on this towards the end. The final 2 points I had mentioned regarding the design of the study: is the study registered? Yes, it is registered with clinicaltrials.gov.in. Was the ethics approval obtained? Yes. Each site was required to have obtained independent ethics approval, and which was obtained appropriately. The third part is probably what most of us would consider important. Are the valid results of the study important? So this you would look at in the results section. So what do you ask to know whether the results are important? Were all participants who entered the study accounted for at its conclusion? Which means, is there any attrition bias? You look at it at the consort diagram. Were the study groups similar at the start of the trial? You compare the baseline demographics of the two arms. Is the recruitment period very long? A very long recruitment period introduces an element of bias because the treatment protocols may change during the period in which the trial is conducted, and when the trial is finally published, the intervention may no longer be an active intervention. So it's all important to keep the recruitment period as short as possible. That is easier said than done. Where the effects of the intervention reported comprehensively. Now, this is the probably a most important part in the results that you need to pay attention to. Are the adverse events detailed? Do the benefits of the intervention outweigh the harms and the costs? And any ancillary analysis, including subgroup analysis, were they pre-specified and exploratory? All these information you will find in the results section. And the last question, whether they were pre-specified and exploratory, you look for in the study protocol. Now, coming to the consort diagram, it is mandatory for all randomized trials now to publish this flow chart called the consort diagram. It starts with how many patients were assessed, how many were found to be eligible. Here 200 patients were assessed, 16 were excluded, 6 of whom had intraoperative metastasis, 4 met unresectability criteria. So 10 patients were excluded because they did not actually meet their eligibility criteria. Now this happened because the randomization was done before surgery. So there was no way they could have included these patients. So finally, 184 patients were randomized, 95 in the surgery alone or the control arm, and 89 in the adjuvant HIPEC arm, that is the intervention arm. And all the patients who were randomized and allotted to each of the arms received the intervention. Subsequent to that, there were dropouts when it came to adjuvant systemic chemotherapy. 30 patients discontinued intervention in the surgery alone arm and 26 in the intervention arm. So finally, 65 were analyzed for the primary endpoint as per protocol, and 63 were analyzed for the primary endpoint as per protocol. So were losses to follow-up and exclusions after randomization accounted for? Yes, they have mentioned how many patients were had discontinued interventions and the reasons for that. Were there systematic differences in withdrawal from the trial arms? No. More or less comparable withdrawals in both the arms. Were all participants analyzed in the arm to which they were randomized? This is called intention to treat. Some trials use a modified intention to treat analysis. So they analyze the primary endpoint mainly using the intention to treat analysis. They also did a per protocol analysis, which was pre-specified. But more importantly, the primary analysis was an intention to treat analysis, which means they analyzed these 95 patients in surgery alone arm, 89 patients in the adjuvant HIPEC arm. So let's look at the results. 200 patients were recruited over a period of 5.5 years. Is the recruitment period too long? Yes. To recruit 200 patients from 17 centers, it took 5.5 years. Were the study groups similar at the start of the trial? Mostly yes, but there were some differences between the two study groups in terms of some molecular markers. MSI high was almost double in the intervention arm when compared to the control arm. The wild type KRAS was slightly higher in the surgery arm. We will discuss this later as to how this could have influenced the trial results. Again, the laparoscopic approach was used more often in the intervention arm. This also could have had some bearing on the results. Now, as I said, it took 17 centers over 5 years to recruit 200 patients on an average, which means each center recruited 2 patients per year. So this begs the question, are these high volume centers? Remember, the Colopec trial took only 2 years to recruit the same number. And I think it was conducted in around 9 or 10, I'm not sure, but it was also a multi-center trial. So we don't know how experienced these centers were. They have not mentioned anything about the credentialing. Now, how will this influence the results? Probably not. In one way, this is helpful because this trial becomes more pragmatic in the sense that many people do very few surgeries, including HIPEC, per year. So if you concentrate your cases only in very high volume centers, then the study results would be applicable only to high volume centers. So you can look at it either way, but the fact of the matter is the recruitment period was quite long. Now, incidence of MSI high tumors, as I mentioned, was almost double in the intervention group. MSI high is associated with a higher frequency of peritoneal metastasis in colorectal cancer, 40% versus 12%. So per se was the HIPEC group already biased towards developing higher incidence of peritoneal metastasis. This is something that you should keep in the back of the mind. Again, the incidence of wild type KRAS was more in the control group. Could this have influenced the choice of targeted therapy at relapse? We all know that cetuximab is indicated in a wild type KRAS. So if the HIPEC group, if the control group had a higher proportion of KRAS wild type, is it possible that they would have received more cetuximab when the patients relapsed? And was this one of the reasons why the overall survival did not show any difference? We also know that RAS mutations have a better survival in colorectal peritoneal metastasis. So this probably favors the HIPEC arm. So there are a lot of factors at play here with just one KRAS wild type difference. So these things you must remember while you are interpreting the results of this trial. Again, 12 to 19% had laparoscopic surgery, more proportion in the HIPEC arm than in the control arm. Now, we know that laparoscopic surgery can miss peritoneal metastasis. So the patients who underwent peritoneal metastasis, is there a possibility that, patients who underwent laparoscopic surgery, is there a possibility that the surgeon had missed already pre-existing peritoneal metastasis? Would that have made a difference to the results of this trial? So these are factors that we need to think about. Now, coming to the main result, a median follow-up of 36 months, 12 patients had loco-regional relapse, 2 patients in the HIPEC group, and 10 patients in the comparator group. Now, this is one sentence that we just tend to read and ignore, but I'll show you how very important this number is. I would probably give more importance to this sentence than to the subsequent sentences in the results. So they say that in the intention to treat population, the 3-year loco-regional control rate was 97% in the HIPEC group and 87.6% in the comparative group. The hazard ratio was 0.21, 95% confidence intervals varied between 0.05 and 0.95, and it was a statistically significant result. So this is the Kaplan-Meier curve. You can see that this curve start diverging at around 7 to 8 months, and they continue to diverge at 3 years. The 3-year disease-free survival rates, however, was not significantly different between the two groups, 81% versus 78%, nor was the 3-year overall survival, 91% versus 92%. So the primary endpoint showed a statistically significant difference in the 3-year loco-regional control rate between the intervention group and the comparator group. But the secondary endpoints of DFS and overall survival was not significantly different between the two groups. But I am more interested in these two values. How many patients had an event, that is a loco-regional relapse? 2% in the HIPEC group, that is intervention group, and 10% in the control group or the comparator group. Now, if you look at the other results, the ostomy rate was, I think, little more in the surgery-only group, probably because they had a higher incidence of patients with a left-sided tumor or an upper rectal tumor. There was no significant difference in the neutropenia. The severe neutropenia rate was only around 2.2% in the HIPEC group. It was not significantly different from the control group. These are important results as far as the morbidity goes. The major morbidity was 23.6% in the HIPEC group and 17.9% in the surgery alone group at 30 days. At 90 days, it was 25.8 and 17.9%. 30-day mortality was 1% in the HIPEC group and 2% in the control group. None of these were statistically significant. So, were the results of were the effects of the treatment reported comprehensively? Were the results reported for each outcome in each study group? Yes, they had mentioned individually what was the outcome in both the arms or for all the outcomes. Was the magnitude, the statistical significance and precision of estimate of treatment effect reported? Mostly yes. For binary outcomes, Were relative and absolute effects reported? No, most trials don't report it. It is for us to decipher this data from the data that has been provided. Were the adverse events detailed? Yes. Were there differential dropouts between the study groups that could have affected the results? No. So more or less, the results are reported comprehensively. Now, this is something that is not reported in the trials, but something that is very essential for you to know whether this trial can change practice. This is called the treatment effect. How big is the treatment effect? That is the magnitude of the treatment effect. How likely is it that the result obtained is due to chance alone? This is the statistical significance of the treatment effect. How precise is the estimate of the treatment effect? This you will know by looking at the confidence intervals. So these three aspects of the treatment effect one needs to see: the magnitude, the statistical significance, and the precision of the estimate of treatment effect. Now, the magnitude of the treatment effect can be expressed in different ways. Most often it is expressed as a hazard ratio, but there are other ways of expressing it, like the relative risk, the absolute risk difference, the number needed to treat, and the odds ratio. But usually odds ratio is not used in randomized control trials. They are most often used in case control studies or cohort studies. So most trials report the hazard ratio, but we need to look at the other treatment effects also. Now, this trial, they have reported that prophylactic HIPEC is effective in reducing the primary endpoint of locoregional recurrence. But is that enough for you? We also need to know what is the magnitude of this effect. So for this, you go back to the drawing table, to this 2x2 table that you probably learned during MBBS, which most of us have conveniently forgotten. So just this is where I told you these numbers are important. What is the number of events in each group? Was there locoregional recurrence? 10 patients in the control group, 2 patients in the intervention group. Who are the patients who did not experience an event? And how many patients were randomized in each group? Very simple. Just draw this table and you can calculate all these measures of association, all these measures of the magnitude of effect. Now, the three important things besides hazard ratio that will give you an information regarding how big is the treatment effect are the absolute risk difference, the number needed to treat, and the relative risk ratio. The calculation most of you would be familiar with. If you don't know them by heart, you can always refer to any book and then use this table to calculate. So the absolute risk difference in this trial is minus 9.1. That is a 9% absolute risk reduction at 3 years. The number needed to treat is 1 by the absolute risk difference. So 1 by 9, that is 11. 0.11, which is 11. The relative risk ratio is 0.187. So the relative risk reduction is 1 minus 0.187, which is 81.3%. The hazard ratio they have already reported is 0.21. Why is it important to calculate all this? Because we need to explain this trial to a patient before advising him that there is a new treatment that has come that has shown to have some effect. Do you want to undergo that treatment? How do you explain this to the patient? If you just tell the patient that there was a 97% locoregional control rate versus 87% locoregional control rate, patient is just going to stare at you. He's not really going to understand what that means. There are different ways you can explain the same result to the patient based on the measures of association that you have just calculated right now. And based on that, you determine whether each of these effects is a big effect, is it a moderate effect, or is a small treatment effect. Now, the risk of peritoneal recurrence with prophylactic HIPEC is 0.18 times the risk of peritoneal recurrence with surgery alone. This is the relative risk reduction that we calculated. If you go here, the relative risk reduction is 0.18. So this means that a patient with a clinical T4 colon cancer will be 18 times less likely to develop peritoneal recurrence when treated with prophylactic HIPEC than without it. Now, this is something that the patient can relate to. Instead of giving a 97% versus 87%, you tell him that you are 18 times less likely to develop peritoneal recurrence if you are treated with HIPEC. He will relate it to it better. I would probably call this a moderate effect, not a big effect. Now, if you look at the hazard rate, prophylactic HIPEC for T4 colorectal cancer reduces the risk of peritoneal recurrence by nearly 80% relative to no HIPEC. Now, both the hazard rate and the relative risk reduction in this trial are pretty much the same. So you tell this to the patient, he'll immediately jump up and say, I want to have HIPEC. Because you're saying that by giving HIPEC, there's an 80% reduction in the risk of peritoneal recurrence relative to not receiving HIPEC. This obviously you would call as a big treatment effect. But remember, this is 80% relative to not receiving HIPEC, which means it is 80% of an only 11% incidence of peritoneal recurrence without HIPEC. In the control group, there was a 10.5% to 11% incidence of peritoneal recurrence. HIPEC is going to reduce that 11% by 80%. So please remember that this is always relative to the baseline risk. So this 80% may not sound very great if you look at the baseline risk of developing peritoneal recurrence. Now, the absolute benefit of prophylactic HIPEC is a 9% reduction in peritoneal recurrence. What does that mean? For every 100 patients treated with HIPEC, 9 additional patients will be locoregional disease free at 3 years compared to 100 patients treated with surgery alone. So this is the absolute risk difference. I would call this a small effect. What about the number needed to treat? 11 patients need to be treated with HIPEC to prevent 1 patient with locoregional recurrence in 3 years. Number needed to treat, always you need to mention what is the time period in which it is going to reduce the recurrence. So the NNT here is 11. So this is probably a moderate effect. Anything around 10 would be a big to moderate effect. If you get numbers as high as 80 to 100, that is a small effect. So these are the different ways we can explain the same results of this trial to the patient in a way he can understand it much better. And we would also be able to understand the results of this trial and how big or small the treatment effect is. Now, rather than using the relative risk, it is preferable to use either the absolute risk reduction or the number needed to treat to come to a conclusion regarding the treatment effect of a clinical trial. So it is better to make decisions based on either absolute risk reduction or number needed to treat rather than a relative risk reduction. Smaller the number needed to treat, larger the treatment effect. Bigger the absolute risk reduction, bigger the treatment effect. And also remember, treatment is more likely to be clinically worthwhile when it reduces the risk of an otherwise high risk event. Here, the control arm had a very low risk, low incidence of peritoneal metastasis. So is this treatment going to be clinically worthwhile when it is going to reduce an already low risk to still lower risk? That is something that we need to discuss. The other outcomes, they have done pre-specified subgroup analysis. They have done per protocol analysis. Again, they found there was no difference. Now, one important thing, the actual correlation between the radiological T4 and pathological T4 was only around 64%. And they even looked at the subgroups with who actually had a pathological T4 disease. They found that HIPEC showed a bigger benefit of locoregional control rate in this group, 98% versus 82%, which means a 16.2% absolute risk reduction. So the only 2 things on subgroup analysis which actually favored HIPEC was pathological T4 and patients who had received adjuvant chemotherapy. Now that you have gone through all the results, you need to make a decision. Does the treatment outweigh the harms and the costs, the benefits. If you look at the loco-regional recurrence, the hazard rate is 0.21, relative risk reduction is 81%, absolute risk difference is 9%, number needed to treat 11%. If you look at the complications, the safety 30-day morbidity is 23%, 90-day morbidity 25%, which is more or less what you would observe in any major surgery, with no significant difference between the intervention and the control arm. Severe neutropenia is only 2.2%, and 30-day mortality is 1%. So the balance tilts in favor of benefit rather than harm. The fourth point that we need to look at is, are the valid results of the study applicable to my patient? This is the external validity. How do you see that? Are the study participants similar to patients in your care? As far as I am concerned, I see colorectal cancer patients who present at a slightly younger age. I see them with more signet ring cells, and they are less frequently MSI high. So they are not exactly the same patients as in this cohort. They are more or less the same, but with probably slightly more high risk features. But overall, they are more or less comparable. Are the outcomes important to my population? That is the outcome of clinical significance. Now this I will come to in a short while. Is the intervention described in enough detail for you to reproduce? Yes. Do I have the resources to introduce this intervention in my practice relative to the time required for the intervention, the finances, and the skill? Yes. Although the dose of MMC, that is 30 mg per meter square, may not be acceptable to many. Many of us, I know, use only 12 mg per meter square. That is the Basingstoke protocol. So how reproducible this will be to those people, I am not very sure. So the other things we need to discuss and the results is there is no improvement in the overall survival. Why was there an improvement in the locoregional control rate, but not an improvement in the overall survival? There could be different reasons for that. We don't know how the patients were treated at relapse. Maybe the patients who did not undergo HIPEC in the control arm received HIPEC when they had a peritoneal recurrence. Was there a difference in the molecular biology, as I already mentioned? The MSI high status and the KRAS wild type difference could have contributed to difference in the survival. The cetuximab use could have been higher in the control arm. So there are various reasons why the overall survival could have been different. Now, keep in mind that 80% of studies that do not report a gain in overall survival, in spite of a better progression-free survival, had an imbalance in the post-study therapies. Here, we are handicapped because we do not know what was the treatment given at the time of relapse. For clinical trials that show a PFS benefit, just because the overall survival does not show statistical significance, it does not mean that there is no improvement in the overall survival. You must understand that a more number of patients are required to identify a true difference in the overall survival with the same power in the trial, which shows that a PFS benefit if the survival post-progression is reasonably large. That means that once the relapse has happened, post-relapse, if the survival is more than 12 months, then you need a much higher number of patients to actually show a true difference in the overall survival. So this is a very recent study which showed, based on nearly 20,000 patients, that extended survival after recurrence reduces the association between the treatment effects on 3-year disease-free survival and 5-year survival. So in modern adjuvant trials, 6 or 7 years may be required to demonstrate overall survival improvements. That is why most of them prefer to use disease-free survival as a primary endpoint, because it gets done quickly. So please remember, just because overall survival did not show an improvement, that does not mean that there is no real improvement in the overall survival. Now, is it acceptable to say that there is no overall survival benefit, therefore this trial is not clinically worthwhile? As far as I am concerned, in my practice, I am quite happy with a better relapse-free survival, even if it does not translate into a better overall survival. Because in my practice, early identification and treatment of metachronous peritoneal metastasis is very difficult. So such patients are rarely going to be eligible for CRS HIPEC when they develop metachronous peritoneal disease. So I am happy if I prolong the relapse-free survival for these patients, because they are unlikely to receive CRS HIPEC when they relapse. They are unlikely to receive expensive targeted therapies on relapse, which is probably what these patients in this trial would have received. So my patients are not going to be able to receive most of the treatments, expensive treatments at relapse. So I am not going to be able to improve their overall survival. I am happy with improving the relapse-free survival. And for the same overall survival, if you prolong the relapse-free survival, that means you are reducing the time that the patient spends in the hospital and reducing the out-of-pocket expenses that the patient has to spend post-relapse. Now, how does this trial compare to a similar study? I will discuss the Colopec trial. As I also already told you, it differs in the inclusion criteria, the timing of the surgery, and the agent used for HIPEC, as well as the method of assessment. Colopec trial, all patients were required to have a laparoscopy if they did not show any signs of disease at 18 months. The peritoneal free survival at 18 months was not significantly different between the control group and the intervention group in the Colopex trial, 80% versus 76%. And they concluded that adjuvant HIPEC did not improve peritoneal metastasis free survival. Now, why is there a difference between these two studies? Other than the difference in the inclusion criteria and the timing of the surgery, the delay in the HIPEC in the Colopec arm, in the Colopec trial, would have meant that the tumor cells would have got entrapped in the fibrin matrix, thereby reducing the efficacy of HIPEC. Again, use of oxaliplatin. Now there is a general tendency to believe that oxaliplatin used for 30 minutes is probably not a good agent of choice for HIPEC. So there are very many reasons why this study is different from the Colopec study. So the final thing that you need to see is the study reported without spin or bias. Is there a significant conflict of interest? What about the funding? Have they acknowledged the funding? Yes, they have mentioned towards the end that this was funded by a public health trust. The role of the funder in the study is mentioned. What you need to see is how involved was the funder in the design of the study, in the analysis, interpretation, as well as writing the manuscript. You will see some pharma studies where the company is involved in all stages of the study. So that you need to take the entire study with a pinch of salt. Here they have clearly mentioned that the funder had no role in any aspect of this study, except for providing the funds. Did the study use a ghostwriter? This study did use a ghostwriter, and they have acknowledged that they have used a ghostwriter. Is there any spin in reporting? Has the primary endpoint been explicitly defined in the abstract? Yes. The primary endpoint should reflect real benefit to the patient. Now, I would probably differ with most of you here who believe that overall survival is what actually reflects real benefit. But for me, an improvement in the primary endpoint of locoregional control is beneficial to the patient. The concluding sentence of the abstract and text should relate only to the primary endpoint. Yes. Abstract and text should include a statement on major toxicity. Yes. If the subgroups were analyzed, were they pre-planned and exploratory? Yes. Are the limitations of the study discussed adequately? Most of the limitations have been discussed. So I don't find any spin or any jugaad in the reporting of this study. So finally, what are my thoughts on the study? To go back to the 5 questions that we initially asked. Does this study address a clearly focused question? Yes. Did the study use valid methods to address this question? Mostly yes. Are the results of the study important? Yes. Are they applicable to my patient? I would say yes. Is there any spin or bias in reporting? No. So overall, this is a well-conducted study, which is the strength of the study. Now, what are the limitations of this study? I could only name 2 major limitations. One, the magnitude of effect is not big enough. The reasons for this: sample size was inadequate. They've used cytoreductive surgery in controls, which by itself, if you go by what Aditi has published, 12 to 15% occult metastasis in the omentum and a 4% occult metastasis in the ovary. By just doing the cytoreductive surgery itself, you bring down the rate of peritoneal metastasis even in the controls. That is probably one of the reasons why the magnitude of effect was not big enough. Again, there was a poor concordance between the clinical and radiological T4 staging. That is one major limitation. That is the magnitude of effect not being big enough. Second major limitation, no details of post-relapse treatment was provided. Some other minor limitations, according to me, the quality of life was not reported, although it is mentioned in the protocol, and the quality assurance was not reported. Now, I already mentioned this about the sample size calculation. They had assumed a 36% incidence of peritoneal recurrence in the control group. But in the actual trial, the control group had only a 10% locoregional recurrence. That is a 26% difference in what was assumed and what was observed. Second, the minimal clinically relevant difference was assumed to be 18%. But the absolute risk reduction with HIPEC in this trial that was observed was only 9%. Now, I fail to understand why they assumed a very high risk of peritoneal recurrence, probably to reduce the sample size. But I think that has probably affected the clinical worthiness of this trial. Even the Colopec trial, which had included perforated tumors and ovarian metastasis, had only a 24% peritoneal metastasis in the control group itself. So whenever you're calculating sample size, the minimal clinically relevant difference must be clinically relevant as well as biologically plausible. We need to be conservative in our estimates. So even though there was a significant difference, now it is very easy to say, so what if the sample size was inadequate? Even with this inadequate sample size, they showed there was a statistical significant difference between the control and the intervention group. But that sample size was calculated for an 80% power. But when you actually look at the difference in the primary endpoint between the two groups, the power of the study would have actually come down to somewhere between 60 to 65% from 80%. More importantly, if they had had a proper sample size calculation with a larger sample size, we probably could have seen a bigger magnitude of treatment effect, that is benefit with HIPEC in this trial. Again, identifying T4, the poor concordance, there was only 68% concordance. So what does this mean? Prophylactic HIPEC may have been an over-treatment for 32% of patients. And this again adds to the magnitude of the thing, because even including T3 patients, the assumed sample size was very large. I mean, they assumed absolute risk difference was very large. Now, this could have been partly overcome if randomization was done intraoperatively rather than pre-op. It's not always possible to identify T4 even intraoperatively, but at least a proportion of patients, if you see there is disease on the surface of the serosa, we know for sure that they are a T4 disease. So again, probably they should have done the randomization intraoperatively rather than preoperatively. This, I think, we have already discussed a couple of times regarding the post-relapse treatment. So what can we infer from this study? Prophylactic HIPEC for clinical T4 colorectal cancers reduces the risk of peritoneal recurrence by nearly 80% relative to no HIPEC, with an absolute risk reduction of 9% and the number needed to treat of 11. So overall, I would put the treatment effect as small to moderate. There is no improvement in overall survival. There is a poor concordance between radiological and pathological T4 stage in colon cancer. Hence, almost a third of patients may be overtreated with prophylactic HIPEC if you go only by the radiological staging. Decision on HIPEC can be better made intraoperatively if serosal invasion is present rather than on pre-op imaging. Will this change practice? There's a a statistically significant improvement in loco-regional control. It does show that HIPEC is effective, but is this effective enough? Is there a clinically worthwhile improvement in the loco-regional control? I would say probably not, because the magnitude of treatment effect, in my opinion, is probably small to moderate. So once again, you come back to the first slide. Please understand that a positive study does not always need to be a practice-changing study, whereas a negative study can sometimes be a practice-changing study. So you once again look at how the study was conceived, how was it designed and conducted, how was it analyzed, interpreted, and reported. For those of you who want to read more, I would urge you these articles, especially this one on how to read a paper by Trisha Greenhall. It's a very good book, gives you all the fundamentals, gives you some checklists on what to see while doing a critical appraisal of an article. So thank you. I would just leave you with these points for discussion if any of you are interested. You're muted, Prashant. Okay. Right.
Yeah. Okay.
Yeah. Okay.
Yes, sir. Sir, thank you very much. I think it was a wonderful critical appraisal of of the trial, and a lot of points actually been brought out. So before I go on to trouble you with a few questions, so I'm going to be putting very general questions because I think related to the trial, there's nothing more to discuss. You brought out each and everything. So some of the questions which I also would like to, when you design a trial, would you consider intention to treat analysis or per protocol analysis? I mean, this is question from Dr. Arun. Like, what would be your choice, and what are the benefits of using either of them?
Yeah, so it is always preferable in a randomized trial, especially a superiority trial, to use a intention to treat analysis, which means you are analyzing all the patients who were randomized to that particular arm, regardless or not whether they had received that treatment. Some trials use a modified intention to treat analysis, which means a patient is randomized, but he withdrew from the study even before he received any treatment. So those patients are excluded. All the other patients who started treatment, even if they have received just maybe say 1 out of 6 cycles of chemotherapy, even those patients are included in a modified intention to treat analysis. So it's always better to use an intention to treat rather than a per protocol analysis, because in a per protocol analysis, you are only taking care, analyzing those patients who have received the complete protocol. If you don't include all the patients, you lose out on very important information. Says you randomize 100 patients, only 50 patients completed the protocol. If you analyze only these 50 patients and say that the result is better in that arm, you're failing to see why those 50 patients who were not analyzed were excluded. It could have been because they had some serious toxicity because of the treatment. So you are missing out on that. So it's always important to do an intention to treat analysis in a randomized trial. Sometimes in a non-inferiority trial, a per protocol analysis would be used, which I was given to understand is acceptable. But generally, in a superiority trial, an intention to treat analysis is always better.
Or in an equivalence also, if you want
Equivalence
to
also,
prove equivalence
yes.
also, or superiority, ITT is something that which is very important, as sir rightly brought out. Sir brought out a very important point. Like, if you have the toxicity of an intervention is very high and there are too many dropouts, then that may actually skew and say that if in case these patients undergo the whole thing, they do better. But actually, you're forgetting that the whole toxicity profile has not been taken into consideration. So Gaurav has a question on, loco-regional recurrence rather than peritoneal recurrence. Why did they specifically use? I think probably it's interchangeable. What they meant loco-regional is probably, peritoneal recurrence only.
Yeah, Gaurav, actually, I had a slide with exactly this point for discussion. Why they used loco-regional? They could have just used peritoneal. And I was about to ask, does HIPEC actually reduce loco-regional recurrence? They had mentioned recurrence in the tumor bed as part of loco-regional recurrence. Now, if you go by the cell entrapment theory, which was proposed by Sugar Baker, HIPEC will reduce the incidence of tumor deposits anywhere in the peritoneum, which also includes the tumor bed. Because if there was any residual tumor cells in the tumor bed, that will later get engulfed in fibrin, making it impervious to any form of treatment, either systemic or intraperitoneal. So I think probably that is the rationale they used to coin the term loco-regional recurrence rather than just peritoneal recurrence.
Thank you. Yeah, yes, sir. So, sir, a few questions from my side. I know you said that, in a subgroup analysis. So generally, sir, I'm not specific pertaining to this because it's critical appraisal of a paper. So if you have a subgroup analysis, can you actually take that and keep that as your standard of care? Would that be practice changing?
No. Subgroup analysis, number one, they should always be pre-specified or pre-planned. It has to be written down in the protocol. It is not just that, I did not get say, for example, suppose this, in this trial, the primary endpoint, they did not show any statistical significance when they looked at all the patients. But in the subgroup analysis of PT4, which they found there was a higher risk reduction of 16%. They would have probably highlighted that, saying that HIPEC may not work in all patients, but it does work in PT4 patients. Subgroup analysis is always, you have to take it as a subgroup analysis. That is not practice changing. It is only hypothesis generating. Subgroup analysis generates some information which may be used to conduct another study. I'll give you one example of this. If you look at the ARTIST trial, which in gastric cancer looked at adjuvant chemoradiotherapy after D2 dissection. The original ARTIST trial did not find any difference in the primary endpoint, whether radiation was given as an adjuvant or not. But in a subgroup analysis, they found that in N2 disease, adjuvant chemoradiation was found to be helpful. And based on that, they designed the ARTIST-2 trial, in which they included node-positive patients alone. So that is how subgroup analysis can be used as a hypothesis-generating analysis.
So if you stratify these patients, would that be applicable?
Applicable where?
Like if you do a stratified randomization, then that subgroup be, even though they have not specified in the protocol, would that subgroup analysis be a meaningful analysis, meaningful result?
Not really. You can do a stratification after the study has been conducted.
No, before this study. Before this study, you have done a stratified randomization instead of a simple randomization.
But that still does not take away the fact that that is not the primary endpoint. That is still only the subgroup. That it will not be powered enough to determine a significant difference.
I think the best examples are the PRODIGE 7 and the Korean HIPEC trial. You have PCI 11 to 16 showing a benefit, but the sample size is too small. You can't infer that 11 to 16 benefits from HIPEC and apply it to practice. And the same with the Korean HIPEC trial. In the interval CRS group, there is a similar benefit to OB HIPEC 1, but it just adds to what is shown in it just supports that hypothesis that it works in patients undergoing interval CRS.
Yeah. So it's very important for residents, to remember that do not take subgroup analysis and then, code them that they can be considered as the standard of care, even though you have stratified before or you have an unplanned or a planned. If it's a planned subgroup analysis, that means you have taken the sample size into consideration. So it works out to be okay. But if not, then probably it would be very difficult. Sir Ramakrishna, sir, regarding sample size, so here we have, they have overestimated the recurrences. And then they said that, the samples to reduce the sample size because they know the feasibility might not be there. Now, a very, hypothetical question, if you, I will name the trial a bit later, but when they do an interim analysis or, they have realized that in the middle of the trial, the sample size calculation is wrong. Somebody pointed out to them later. And is it possible at that point of time to recorrect the sample size and then, increase it? Or is that possible? Is that ethical? Or,
Yes,
what's
it
the
is
comment on
possible.
this?
It has been done. I don't remember the exact trials, but I have come across trials where they have readjusted the sample size based on the interim analysis. But interim analysis sometimes can be done just for the toxicity or the safety of the trial without looking at any other aspect. So I'm not sure whether they have done that, but I remember reading that interim analysis after 100 patients did not show a difference in the toxicity, so they proceeded with recruiting the rest of the patients. But
So one of the
probably
trial,
may not be able to determine the frequency of events in either arm during an interval analysis if the analysis is done with a very short follow-up period.
so I think one of the classical studies which is recently published is the VGSC study, on the sample sizes. Actually, they had overestimated recurrences. Same way, but then they realize that the recurrences are not really that high because the treatments, what happens is when you have longer duration, like the study goes on for 10 years, treatment strategies change over time. So patients start living longer. So your recurrences start, your recurrence-free survivals are longer. It may not be meaningful altogether. So it is very important that at this point of time, they can intervene and actually change them or modify the sample size. Either it might decrease or increase. So, but it is possible with or without an interim analysis. So this, this was a very interesting concept, but I think it is very important, especially for trials which run over 10 years because the treatment changes a lot and, the survivals get better. So this is something that which was interesting and should be considered. So one interesting point that you brought out, which has always been a point of debate, overall survival versus disease-free survival as primary outcome. We always keep debating living longer is better than, early recurrences. So why did you stress on saying that I would prefer if patients have a better or disease-free survival than having an overall survival? Any take on that, sir?
I didn't say I would prefer having a better disease-free survival than an overall survival.
Yeah.
I said I would accept longer disease-free survival even if it doesn't improve the overall survival. Of course, for a patient, the ultimate aim is to live longer, but he also has to live better. But so this philosophy will vary from person to person, from place to place. In my practice, the patients are not going to be able to afford expensive treatment once they relapse. They are probably not going to be able to undergo a CRS and HIPEC when they relapse because most often metachronous peritoneal metastasis, by the time they are detected, they are quite large and probably not amenable to cytoreductive surgery or HIPEC. Most trials that have come from Western countries, if you look at the post-treatment, post-relapse treatment, they get all sorts of biological therapies, first line, second line, third line, which my patient is not going to be able to afford. So the longer my patient lives without disease is good time spent for him with his family. Once he develops disease recurrence, his survival is going to be short anyway. So even if I'm not going to prolong his overall survival, if I'm able to prolong his disease-free survival, I would be happy with that.
Yes, sir. Nicely put up. So Kazi has an interesting, he has put out a comment. Every interim analysis has to be pre-planned. So it is not that you cannot do an interim analysis, because every time you do an interim analysis, if you have not taken it into consideration, then the power, you start losing patients, and it's not accounted for. So that's a
Correct.
very
Yeah.
important statement to actually take. It's that, can we, so does this mean that we shouldn't be doing an interim analysis, unplanned interim analysis? So what do you do if you have to do an unplanned interim analysis?
This doesn't prevent you from doing an unplanned interim analysis. If the data safety monitoring board feels they need to look at something, if they see an unusual number of adverse events happening, they probably will do an unplanned interim analysis. However, I think this is more of a theoretical question, because most well-conducted trials nowadays do include planned interim analysis, maybe one or at least one, but probably even more than one at different time points.
Yes, sir. Sure. Sir, I think we've covered most of the aspects of the trial, and also, you actually beautifully brought out, what exactly you should be looking for in the abstract also. So, those are very important things that you need to take from the abstract. So I think those points were very nicely brought out. So that whether you can actually, these are abstracts. It's not possible to read each and every. Actually, the first question in the chat box was, which are the journals that you need to read regularly and other things. But actually, you need to read and understand the abstract. It is humanly impossible to read each and every trial that gets published in each and every article. But I think so a quick abstract review and understanding how the abstract is, and then choose them, and then, you could go about. There's no one good or bad journal. Everything is good as long as it's going to change. So you cannot restrict yourself to 3 or 4 journals. I think WhatsApp groups have made our job easy by posting landmark publications as the fastest mode of communication, so that we are all updated wherever we are. So
I have a question. What about changing the primary endpoint of a trial? Sometimes, like I'm talking with regard to the OV-HIPEC 1 trial, the primary endpoint was overall survival, and then there was slow recruitment. So in between the trial, the primary endpoint was changed to progression-free survival, and the sample size was recalculated and reduced. So what do you have to say about that?
I am not really an expert in that. So, but yes, it does happen, not very frequently, thankfully. But I suppose that if the sample size is calculated appropriately, we can accept it, although we need to go into the reason why the primary endpoint was changed. This is like shifting goalposts halfway through the game. So
I think because of slow recruitment. So when you shift the endpoint from OS to PFS, you have to recruit lesser patients.
I don't see why you should be able to recruit more number of patients by shifting the endpoint. I'm not sure about that.
No, they required less patients when they recalculated using PFS. So
Okay,
they were
sample
able
size
to
was
complete
less.
the trial, which they were not able to do with OS as the endpoint.
Sir, I think it should be, there are a few other trials which, it should be possible that if they could change the endpoint of the trial. As I said, if the trial is taking too long, and you've calculated you were over ambitious in calculating your sample size, and then but later on, if you put probably a progression-free survival, or probably even time to recurrence or time to event or number of events, if it possible, because a trial which goes on for 10 years, I think would be meaningless 10 years later. So probably it may be applicable, but I think with the DSMB and the ethical approval giving a proper reasoning, I think probably it's not. If you can increase the sample size, I think we should be able to change the other one too.
Yeah, so I think basically what the residents need to take away from this is use a checklist while reading any published article. Make sure that the study is done in a proper way. All the points that was mentioned. There are different types of checklists available. You could use any one of them. They usually cover most of the important points. And more importantly, don't just go by the p-value. Go by the results that you have derived from the numbers provided. The authors don't provide all the results that you would like to know, but usually they provide the numbers from which you can derive whatever results you want, whatever type of association that you want. And then you look at how big is that treatment effect. Just the positive report alone probably is not going to be of use. See how big that treatment result is, treatment effect is.
For the sake of residents, I've just posted an interesting article on the various checklists for different study designs. So if you're interested, you could just go through those articles, because nowadays actually most of when you're writing even for an observational study, you are expected to actually, in good journals, you're expected to actually send that checklist to as a supplementary file. It makes the reviewer's job easy. And also you're very clear. It makes the author's job also easy actually, because it is very clear whether you have covered all the points according to the checklist, and the chances of, if you have not covered, then you yourself know that it is not a publication that you should be sending to that particular. You have missed out. So it is actually good for the authors as well as good for the reviewers too. Thank you very much, sir. If there are no further questions, and Dr. Aditi, if you are fine, then I think we could call off today's meeting.
Thank you, Dr. Ramakrishnan and Dr. Penumadu. I think not just for the residents, even people in clinical practice and who are very much interested in research, this was a very informative and educational session, and thank you very much. And I think there are many requests pouring in for your presentation already. So perhaps we could look into it later if we could have a PDF or something. I'm already getting messages for it. Yeah.
All right. Thank you so much.
Yeah.
I hope this was useful to all of you. Right.
Okay. Thank you,
Good night.
everyone.
Yeah.
Thank
Bye.
you.
Good night.
Thank you.